Well, good afternoon, everyone, and welcome to the St. John's University Power Hour number 17. I am the host of the Power Hour, and my name is Susan Damiani, and I am the Director of Gift Planning, and I'm also the Director of the McAllen Society, which is our legacy society. I welcome our faithful viewers. Thank you for joining us again, and all our newcomers. It's great. The Power Hour was created to stay connected during the pandemic, and it has been very successful. I look forward to it every Tuesday. It's great to see all of us, and we're here to power ourselves up, to learn something new, to expand our minds, and to connect as an alumni family, because that's what we are. Anybody who's connected to St. John's, we are one big happy family. So thank you for joining us today. This is really amazing how time flies, because our first Power Hour was with Dr. Harlem Gunness, because we felt the first one should really address COVID-19. And it was another very well attended Power Hour. And I cannot believe, Harlem, that, how many months later, it feels like we just had the Power Hour yesterday. And I am not going to take away from Harlem's presentation, but he has a lot to share with you, but also some positive news on what has even come out of the Power Hour, and just Harlem and I connecting and networking. So it's been really exciting and inspirational. So we wanted to expand this talk today and include some of our other experts and professionals from the College of Pharmacy and Health Sciences. So we're going to be addressing the efforts that are made by St. John's in this pandemic, the community, the examinations of the community health profiles and with the elevated COVID, and the pharmacist role, which is very interesting. I've been learning a lot about that over the past few months, and perspectives from a healthcare provider. So we have all professors. Now, their backgrounds are just so amazing, and I could probably take up the next half hour just talking about their background. So I'm just going to give a quick little background on each of them so you understand where they're coming from. So many of you already met Dr. Harlem Gunness. He has a long-standing career in public health. He's the director of our public health program here at St. John's. And prior to his assignment, he was the senior officer with the Public Health Service at the CDC. We also have, I don't know where she is on your screen, she's on my upper right screen, Stacey Singer-Leshinsky. She is a physician assistant and a full-time faculty member at St. John's. She is actually receiving the Preceptor of the Year Award for her work with her students, especially during the crisis. Congratulations, Stacey. And working with you just on this Power Hour, I'm not surprised. You have great energy. We have the wonderful Yumi Lee, and she's the Associate Clinical Professor at St. John's. She's a clinical specialist in infectious disease. She works at Nassau University Medical Center. And if you go back to the registration page, she has a thorough background in infectious diseases, very impressive. And with her, joining her as well, is Nicole Bradley, and she is the Assistant Clinical Professor. She practices as an infectious disease pharmacist at Elmhurst Hospital. I thought that was very interesting. So I'm sure Nicole has seen quite a lot during this pandemic. And she precepts our sixth-year pharmacy students there. So with that ado, I'm going to turn it over to Dr. Harlem Gunness, who has become a friend now, and as well as a colleague. And thank you for joining us, Dr. Gunness, and all the professors. And I look forward, like I was saying to Nicole, we are hoping you have the magic wand that is going to get rid of this terrible virus, but at least give us some tips on how we can continue to survive and thrive in this new normal. So I'll turn it over to you. Thank you.
Thank you. It's quite a pleasure to be here and to return to speak to you about where we're at with the pandemic. Uh, say I have to acknowledge your incredible efforts of pulling this team together and pulling our panel together to talk and to share with our distinguished guests, our students, our participants on the significant roles in John University and the efforts the St. John's community is making to combat the epidemic in so many different ways. And this is just a small example of what we're doing that we're going to present to you. So I wanted to come back and speak to you more about, follow up with you actually on what I presented in the first Power Hour. And what I'm going to share with you is really um, I was able to sort of do a bit more deep diving on the analysis of two communities. One community, which is the Corona Elmhurst community, that has the highest number of COVID cases or incidents of COVID, and compare it with some of the findings on the uh, Far Rockaway community, which has the highest number of deaths in Queens and in New York City as well. And as Susan said, then we'll have a Dr. Stacey Singer-Leshinsky talk about uh, her experience as a healthcare provider, actually treating patients and bringing that raw experience back into the classroom setting. And then we'll also talk about the role the College of Pharmacy and Health Sciences on the pharmaceutical perspective or the pharmacy perspective um, by Dr. Yumi as well as Dr. Bradley. Okay, so just to share with you, so I did again looked at what I'll recap from what I presented on the first Power Hour. So I talked about the two community, several communities I looked at in the first Power Hour. I looked at communities that were three communities that were highly affected by COVID in terms of infection and cases, versus three communities that had less cases in Queens. And as we see here, the communities that are less affected were more educated, they had less overcrowding, and they were heavily white or Asian. The heavily affected communities had severe overcrowding, severely uninsured, and had elevated chronic conditions, hypertension, diabetes, or heart disease, and also more avoidable hospitalizations, meaning that they presented to the hospital for a condition that could have been prevented had they received access to primary care. And there were also heavily Latino Black communities. So what I figured that I'll do is dive in deeper in these two communities that had the highest COVID cases in New York City, which is Corona Elmhurst, and look and compare it with the Far Rockaway community that has the highest um, deaths. So my question was, are there any differences in the community with the highest number of COVID cases versus the community with the highest number of deaths? And when I talk about differences, what I wanted to look at is um, some of the nuance in the communities that are often may not be captured. So the health status of the community, or whether they have access to health care, or um, the uh, the um, the 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 demographics of the community, as well as the built environment that had an influence to it, or access to healthcare. Sort of following up on these um, factors that I discovered to see whether or not are do these two communities have uh, similar findings as you'll see in the heavily affected communities, or do they have different characteristics that make them more susceptible to either spreading the disease or deaths from disease? So we see here that in Far Rockaway in the red, you'll see here that the population is over 114,000, But in Corona, it's almost doubled, where it has over 188,000. Now, this is sort of very alarming. You'll notice here where the cases in Far Rockaway, it's only at um, over 21,000 plus COVID cases. And you'll see here in Corona, it has 3 times as more. You'll see it has over, let's see here, over 7,000 cases there. So you see, Far Rockaway in this pie chart only makes up a quarter of the cases. But if you notice, when you compare it with the deaths, Far Rockaway makes up over half of the amount of deaths in comparison to Corona, which Corona has a higher population as well, right? Now, some of the key findings that I noticed in terms of the demographics, you'll see here in Far Rockaway, we have the blacks make up the largest number of in terms of race, followed by whites. So I figured, let me look into that deeper to see whether or not there are any, in terms of the numbers, if they are similar in terms of COVID deaths or infection between blacks and whites in Far Rockaway. And I realized that the majority of COVID cases and deaths were in the heavily concentrated Black communities, which is Far Rockaway proper, not the other areas in the Far Rockaway Peninsula. You see here as well, in comparison to Far Rockaway, you'll notice that in Corona, we have over 60% of those who live or reside in Corona were born outside of the US. As well as you'll see 51% Corona have limited English proficiency, which means reading, understanding English, which really speaks to whether or not they're getting the health education and the health material to prevent the disease that the public health and public health authorities that are disseminating this information. And it begs the question as to where are they getting their information from? Are they getting it from the internet? Are they getting it from a credible or reliable source? Now, you'll also see that in Far Rockaway, it has Asians make up the second largest population. You see here as well that Latinos are at 51%, which is a heavily Latino population in Far Rockaway in comparison to, in Corona in comparison to Far Rockaway. Now, in terms of the age demographic, you see that Far Rockaway has a slightly higher older population. And again, as you think of Far Rockaway, think about the deaths and whether or not, what's the association, or if there are any possible association or correlation with these factors that I'm presenting here in relation to deaths in Far Rockaway versus the spread of disease or incidence of the disease in Corona. So here we have, again, in Corona, we have, not only do they have limited English proficiency, but in Corona, they are less educated in comparison to Far Rockaway. So again, it really speaks to the question whether or not they are getting the health education, the material, or can they change their behavior to prevent the spread of the disease. And again, as I mentioned to you, Latino, it's a heavily Latin population as well in Corona. Okay, so let's look at the health and socioeconomic and environmental characteristics between the two communities, Far Rockaway and Corona. So you see here, obesity in Far Rockaway way outnumbered obesity in Corona. So that's another one of the the underlying disease conditions that that can cause death due to the virus. Also, you see here that in Corona, you have a significant number who are uninsured. So 25% of the population in Corona are uninsured. So that really speaks to whether they have the access to healthcare or means to prevent the virus. Now, you also see here that in Far Rockaway, we have hypertension is at 34%. But really importantly, avoidable hospitalization way outnumbers that of Corona, where it's at 1,345 per 100,000 population, as well as psychiatric hospitalization. It's at 1,158. So that to me is saying that they're not really getting the access to the healthcare that they need to maintain either a mental health illness or a physical illness as well. Now, what is really staggering, you'll see that premature mortality in Far Rockaway is almost 3 times more than that of Corona. Also, heart disease is almost, excuse me, 4 times more than Corona as well. So that really speaks to, whether this community, Far Rockaway, in my opinion, seems to have I guess they seem to have health disparities significantly more than Corona. It's even before the pandemic. So this is data that I'm getting from New York City that's about a few years old, about 2 years old, and you can tell where it has, these diseases has been sort of in the community. They've been struggling to address the disease or to find solutions, I should say, in addressing the disease. And it's telling by the cancer cases as well as the life expectancy as well. You'll see that life expectancy in Corona is almost 10 years less. Sorry, in Far Rockaway, it's almost 10 years less than Corona. Incarceration as well, really, it's significantly high in Far Rockaway. Now, in Corona, on the other hand, you see that poverty is higher than that of Far Rockaway. And the last thing I wanted to point out, you'll see that severe overcrowding is significantly high in Corona, which really speaks possible reasons as to why the disease may be spreading so rapidly versus in Far Rockaway. So the point I'm trying to make here, you will see the distinct differences between Far Rockaway and Corona. Far Rockaway, this is a community that has already been dramatically affected by chronic diseases and health conditions that can be easily prevented, or it can be easily treated with the access to quality health. In my analysis, that Far Rockaway was deemed as a medically underserved community in 2018 by the New York State Controller's Office. Now, you could see where the specifically heart disease and the life expectancy, obesity, things, hypertension. These are hypertension, heart disease specifically, and obesity are related to COVID deaths. Now, when you look at Corona, you will see that a large majority are uninsured. They are more impoverished than those in Far Rockaway. But the big factor here is the environmental factor, where they have severe overcrowding, significantly more than Far Rockaway. So they don't have the housing, affordable housing capacity to house the amount of people that live in Corona. And I wanted to also share that the number of housing units between the two communities are almost comparable, which really speaks to the significance of, even though that their population are almost double. Sorry, in Corona, the population is almost double than that of Far Rockaway. And that is the end of my presentation, and I am now going to share Dr. Leshinsky's presentation now. Okay, take it away, Dr. Leshinsky. Just let me know when to change the slides. Hello?
You hear me?
Yes.
Okay. So my name is Stacey Leshinsky. I am a graduate from Brooklyn College, and from there I went on to work for the Fire Department of New York Bureau of EMS as a paramedic for 10 years before I went to the Catholic Medical Center, which is now the St. John's University Physician Assistant Program. In 2004, I started teaching for the program. And with the help of our college, they provided for us a clinical day to go out and practice. And I thought this was really, really important because it would enhance the education that we're giving our students. It also went with the mission of the university, was to ensure our personal and the professional success in our global society of our students. And how better could we do that than going out there and practicing and bringing the world to our students? You could change the slide. So I've been working in Northwell, Long Island Jewish Hospital in the Department of Cardiology and Internal Medicine since 2016. So just in case you're not sure, we do have a physician assistant program, and we're healthcare professionals. We practice medicine with the assistance of the physician. Common services, we take medical histories, we perform physical examinations, we order and interpret lab tests, we diagnose, we treat illness, we assist in surgery, we prescribe, and we dispense medication. We also counsel patients. And what a physician assistant does varies based on their training, experience, and state law. Okay, you can change it. You could change it. The slide. Okay. So what I had been doing prior to COVID is bringing the classroom to life. So what I did to approach our students, our millenniums, is I developed these Facebook sites where I had a PA EKG discussion board where you can see there's over 260 members at this point. Every year I add the class and we discuss cases that they've seen out clinically or I have seen clinically, and we have discussions. So we're kind of bringing the classroom to life. In addition, I hosted a sim war in January of 2020, where it was an article in St. John's on their news about our students doing this inaugural simulation contest that involves simulation learning. So I took students from all programs that we have in the College of Pharmacy and Health Sciences and put them together to reenact something, a medical condition. And we actually ended up giving them awards. As you can see in the bottom, they had medals and everything else. And it really, really promoted their engagement. My value has always been to engage our St. John's University students and make them as successful as they can be. So we did things like cases, social media, and this interprofessional education to let them know that they're important members of the medical team. So now you could go to the next slide. What happened? And this is the sim war, we called it. So now in March 2020, we had this coronavirus outbreak. And I was actually on WebEx with my students going through class, and they started to cry. And I was like, what's the matter? What's the matter? And they told me, Professor, we just heard that the university is going to be closed and we're never going to be face to face for possibly the rest of the semester. So this had a big impact on our faculty as well as students. Our traditional classroom had to quickly be turned into e-learning. We had to learn how to use WebEx, teaching was remote. We had video conferencing, and it had a large impact on our faculty and students. But as we are as faculty, always with the mission of St. John's, their personal, their professional success. What can I do to do this? And then I looked at my clinical position, and I saw that this was having an impact on healthcare workers. The hospitals were strained, workers were exhausted, and censuses were extremely high. This was a devastating effect to our healthcare team. So I sent a letter to my college dean and I told them, I said, I'm doing what I've been called to do. I'm taking care of patients in a hospital that's desperate for our trained help. We have OB and obstetric and even ear, nose, and throat physician assistants trying to help taking care of these medical patients where our hospital quickly became overwhelmed. And I told him, I told my chair, the mission of St. John's is to serve the underserved. And here I was fulfilling that mission as I helped where my skills were needed in the hospital. And I was doing what I needed to do to help my overstrained Long Island Jewish Hospital. However, I was dedicated to helping not only my community, I went on and continued to help the students as well. The hospital was a mess, and I'll go into that first. Let me talk about how I served our students. So if you could go to the next slide, you could just switch the slide. So here are just some examples of how I served our students. WebEx, oops, previous slide, previous. Thank you. So you could see up in the right-hand corner, this is how we taught. We went from teaching in the classroom to putting on headphones and talking to our students and trying to explain things and point out things that we would be able to do in the classroom. I also put up here some examples of, and it's so funny because the group actually named, I told them we're going to create a Facebook site, and they named it Best Advisor Group of 2020. And they were so engaged. And here you could see these are pictures or histories of patients that I had that I wanted them to be able to look over and go over together. I would review my cases from Long Island Jewish Hospital with them, especially COVID up in the right-hand corner all the way towards the end. That's actually a case that we were going over for a COVID patient that I had. I didn't want them to lose, we had our clinical students that were coming back to us and going on WebEx and having virtual rotations, which are so much different. I emphasized to them, we are a team, we're working together. I am going to make you into a high quality physician assistant with whatever I need to do, whether that be going through FaceTime and, Facebook and going live with them and showing them EKGs and, always hiding, of course, patient information, showing them history and physical exams, going over that just to keep them engaged. And they were so engaged. They really, really enjoyed it and actually led to me being called Preceptor of the Year for 2020. So I'm excited to receive that award soon. You could just go to the next slide. So just to show that I never put the students second, the students were always first. My community was second. Here's a letter that was written by a student that just wanted to express her deepest gratitude for being such an amazing teacher this past year. We all knew coming into this year that it would be one of the hardest years in our academic careers. And we were scared and overwhelmed about all of the information we would be learning. However, the moment you began teaching, I felt at ease because you taught with so much passion and love that I realized what a big difference having a great teacher like you would make. You always have positive encouragement and were always willing to spend extra time with us in office hours or sim lab to help us out. Then once school got shut down because of COVID-19, I was nervous I wouldn't learn as well as I did when in class. Everything was so uncertain. But even though through all of the chaos and your so many hours at the hospital working overtime, you still found time to ensure we would be leaving our didactic year as competent PA students. You spent countless hours over WebEx with us, making sure every student understood the material before you moved on. You really changed my year for the better, and I would like to say thank you for all the extra time and encouraging stories you have taught us. I hope you and your family are doing well, and I'm really glad I got to have you as my professor. This is one. I had so many students wrote me letters because to me, that was my importance. I felt for my St. John students that they should have the same opportunity, even though there's a crisis, and they were scared. They cried on WebEx while I was teaching them, and I made extra WebEx times, did whatever I had to do. So now I talk about that's how I served our students, serving our community. So I started working for Northwell Jewish Hospital per diem in April of 2016. Thank you so much to my department, the college, the university for granting us this clinical day, which I work as a physician assistant, which is an advanced care provider. And we work like a resident. So we have the highest level of provider on medical surgical floors. And I worked here, and you can see in the corners a picture, LIJ being the second citywide for the number of coronavirus patients as per a report. And the bottom picture is just a picture that I sent to my students on one of the evenings because I always worked at night. And I was like, hey guys, I'm here for you. Let's get together. Let's start talking about some cases, and always a smile on my face. And, you know, our hospital was hit very, very hard during the COVID crisis. We had patients in the operating room. We had patients in endoscopy. We took over Cohen's Children's Hospital with COVID patients. They were all over the place. I worked many hours. I started to work full-time there as well as full-time teaching. I would come home after 13 hours in the hospital and work with my students. And why? Because the census was so high. We saw more patients than we ever had seen in our life. I never saw a death rate where we would basically go downstairs to write our death certificates, and there was a line, and the person knew us from the Department of Health. They would say, oh, Stacey, you're back again. And it was like, yep, I'm back again, another one. You get to the point where you would have two patients, you know, in complete distress at the same time, and you didn't know where to go first. It was, you know, and all the back of my head was my students, my students, my students. I have to prepare them so that when they go out there, they need to be prepared for the next pandemic, my graduates at that point. The hospital staff were overwhelmed. Nurses would cry, people would cry. I remember one patient that I had that he was like, no tube, no tube. I don't want to be on ventilator. And I told him, sir, please understand, you need to go on this ventilator. We're going to save your life with it. And he said he didn't want to. And we offered him, because what we would do is we would show FaceTime. We had little computers that they could go on FaceTime and talk to their family and get their family's opinion. They were frustrated. They were alone. Doors were closed because they were airborne precautions. They sat in those rooms alone. The only thing they had was our smile as providers, to be there for them and to help them make those decisions. And this man he just would not accept the ventilator. And when I came in the next day, he had just passed away. And the nurse was crying, and it was so bad. I just went down to the morgue with the patient. I helped them do things that were out of what I'm supposed to do, but I needed to help them. They were so overwhelmed. They were so frustrated. They were so scared that it was important for me to do that and be with them. Like I say, the patients, the doors were closed. I remember one patient, I went in and it was end of life. We would just try what we could, but there was only so much you could do. And I held his hand and I said, it's okay to go. I'm going to hold your hand and I'm going to be here until you pass away. And I sat there and held his hand. And it was such a bad time because, as you can see the picture over here, this is what we look like. We were unidentifiable, two patients, and this is what they saw on a daily basis. The bottom picture is a picture I actually took with bodies waiting to be brought to the morgue. So there were actually 3 lines up, and we would just stand back and watch as they pushed the bodies into the morgue from the hallway who had just been pronounced. There were just so many of them. So this is what they had. Patients were alone. Doors were closed. No visitors allowed. The only people they had were us, like I said. So what I would do is make phone calls every night to my patients' family members just to make sure that they had all the information, that they had the status of their loved ones. I comforted them, and especially towards the end of life when they were suffering or when they felt really, really lonely. And these were all things that I had learned when I was a student at CMC, which is now the St. John's University PA program. And these are all the values that I brought to my students in WebEx and explained to them the importance of the phone calls, the importance of being there. It's not all book knowledge. It's about what you can bring for the psychological health of your patient, how to be a human and treat your patient as a human, no matter what they have or how contagious or what's going on. That's still a person sitting there by themselves. So that was my job. And of course, we were thanked. So here's, we had some times when the police department would come and provide food. And here's just me walking out of work after a long day. And this picture went to my students once again. I was like, hey guys, how you doing? Sign out LIJ. They had signs up, thank you, not all heroes wear capes. And there were little notes that went along the wall. This is where we did our sign out at 6 feet apart. And those notes were so important, including notes from my own students, just supporting healthcare workers from the St. John's community. Go to the next slide. Another thing I started doing, you could go, is I made these, I know how to crochet. So in my spare time, I made, one more slide back. Just go back for a second. So one more slide back, thank you. So I made these little ear savers that they're able to put their one more slide forward, able to put their masks onto. I made all these and wrote the sign, thank you, and gave these to my colleagues working over at the hospital. And I'm in the process of making 75 ear savers for our St. John's students. Hope you like the colors. So I'm in the process of doing that for the students. So I'm so dedicated. That's just my way. And I want to say a special thank you to all of you, our donors that have made St. John's possible so that we can bring what we bring to the students and to the community, because that's so important. And if I just had one message for everybody, it would be, yes, wash your hands, wear your gloves. It's really, really bad out there. And our students are out there now. They started rotations on Monday. The only thing is they are down on N95 masks that are really, really important. So that's one thing I wish I could raise funds to give to them. Thank you.
Next, we're going to have
Wow, thank you.
Dr. Lee and Dr. Bradley.
Oh, okay. So thank you, everyone. I'm just waiting for the slide to go just to the first slide. But in the meantime, I can say thank you for this opportunity to allow us to have this moment to speak with everyone today about the role of pharmacists, and specifically our own faculty, that we've been playing during this pandemic. So I guess, what we've been seeing, and I think Stacey really put, her experience, into life for us. What we've been seeing during the coronavirus is that as it spreads throughout the country, the supply of qualified healthcare providers become limited. I think often when people think about healthcare, providers, they think about doctors and PAs and nurses. But if we just pause for a moment to think about this, how easy is it for you to pick up the phone or walk into your local pharmacy to actually have a conversation, with a pharmacist? So statistics actually show that 90% of Americans live within a 5-mile radius of a pharmacy, which I think really highlights how accessible we are to the community, and as pharmacists who, we are part of the healthcare team. So this slide here that we have up on the screen, really, I just wanted to give everyone a background in terms of the pharmacist scope of practice. So as pharmacists, we are clinically trained at the doctorate level. Our PharmD education includes pathophysiology, pharmacology, therapeutics, clinical problem solving, medication use, of course, and laboratory monitoring as well. So just to give a few examples of our background and training. So after we obtain our PharmD degrees, we can also complete postgraduate training and fellowship programs as well. We can become board certified and obtain additional advanced pharmacist certifications. So depending on the state, pharmacists also have the authority to test for and treat infectious diseases such as influenza and strep infection. So for example, in Idaho and more recently in Florida, pharmacists are authorized to prescribe products to treat strep and flu following a rapid diagnostic test. So at the moment, I believe only 17 states permit pharmacists to test and treat. A majority of the US allow for pharmacists to practice in a collaboration with prescribers. So in other words, this means that a pharmacist can collaborate with a physician to order labs, interpret results, and then prescribe or make dose adjustments on the medications as necessary under a collaborative practice agreement. And nearly all practicing pharmacists have been trained to administer vaccines to patients of all ages. Pharmacists have been playing a critical role in increasing influenza vaccinations across the United States, which has resulted in less influenza infections. So kind of to sum it up, pharmacists really provide a wide range of patient care, and we can also work in a variety of settings, including hospitals, clinics, community pharmacies, long-term care facilities, even medical homes and physician offices. Pharmacists do serve a critical role in patient care and the public health. So the slide here, in order to empower pharmacists to fully and effectively support our nation's COVID-19 response, and in order to ensure that patients get the help and treatment they need, the major pharmacy organizations in the United States came together and they released this joint set of policy recommendations critical to addressing the COVID-19 pandemic. So in this executive summary, they are urging policymakers to authorize all pharmacists in testing, interpreting, initiating treatment, and counseling patients, not only for strep and influenza, but also COVID testing. They're also asking to expand the immunization order to include all FDA-approved vaccines, including the forthcoming COVID vaccine. They're asking actually for the authority for pharmacists and pharmacy technicians with valid licenses to be able to operate across state lines, including telehealth. And I think Stacey also touched on this topic. She talked about the workforce and the workflow issues, how there was really a lack and limitation to healthcare providers. So hopefully by allowing pharmacists and pharmacy technicians to operate across state lines, we can help address some of these workforce issues. And also in order to provide continuity of care, we're asking pharmacists to have the authority to conduct therapeutic interchange and substitution without physician authorization. And this is only when drug shortages arise. And lastly, for pharmacists to be reimbursed for these services in order to maintain financial sustainability critical for public health needs. So while these major organizations are working together to advocate for pharmacists, a lot of pharmacists have already taken roles as first-line responders during the COVID pandemic. So in the next couple of slides, Nicole and I are going to do our best to share with you what some of our own PharmD faculty at St. John's University have been doing in response to the pandemic. So here we have, you see her picture right here, we have Dr. Samantha Moore, who is an assistant professor at the College of Pharmacy and Health Sciences. She has an affiliated practice at Bellevue Hospital in Manhattan, where she practices as a clinical pharmacist in the ICU. Her quote when we asked her about her experience working at Bellevue during the pandemic, in her exact words were, "The best I can describe it is what I would expect in a war zone. Everyone was barely keeping their heads above water and just trying to keep patients alive." Dr. Moore rounded twice a week with a different team each day, covering about 40 patients a day. All 4 of the ICUs at Bellevue, plus 2 additional floors, were turned into COVID ICUs, with all patients doubled up in rooms. So IV pumps, instead of being kept inside the rooms, were kept outside of the patient rooms with IV tubing extensions to minimize exposure for the nurses. A majority of providers and nurses were travelers from out of state, and many of them had no ICU experience. There was a shortage of medical supplies and equipment. So specifically, Dr. Moore shared with us that due to a shortage of IV infusion pumps, certain medications such as insulin and heparin had to be given subcutaneously instead of intravenously, even if it meant suboptimal care. Dialysis filters were also on shortage, and that resulted in the use of peritoneal dialysis in the ICU, which is not usual in the ICU setting. And pretty much everyone was desperate to try anything that they could. Next slide, please. So Dr. Moore provided her, thank you. So Dr. Moore provided her services twice a week in April during the height of the pandemic, and she has now returned to being at Bellevue 5 days a week. So her major contributions went into optimizing medication management. There were a lot of issues with medication dosing and adjusting for patients with their rapidly changing renal functions. So a lot of Dr. Moore's efforts went into making sure that patients were on the right doses of critical medications such as anticoagulation, analgesics, sedatives at all times. She also played an active role in antimicrobial stewardship, which is making sure that antibiotics are being used appropriately. She reviewed microbiology results to optimize antimicrobial therapy. And to prevent medications from falling off, as many COVID patients had extensive stays in the hospital, Dr. Moore reviewed patient profiles to ensure the continuation of the necessary medications, as well as discontinuing any medications that were no longer necessary. Next slide, please. So here, the next faculty that we wish to spotlight is Dr. Sarah Smith. She is an associate professor at the College of Pharmacy and Health Sciences and a pediatric clinical specialist at New York Presbyterian Weill Cornell. So her words when asked to describe her role during the pandemic was, "It was deeply disturbing to so many facets of life. Feeling unable to change what was happening, not knowing what would happen exactly, not being physically with the team to effectively work together, and worrying for the well-being of my colleagues at the bedside. It was stressful because of the drug shortages, making it very hard to care for patients." So during the pandemic, Dr. Smith provided her pharmacy services remotely to both NYP Cornell Komenski Children's Hospital and NYP Stanley Children's Hospital, and she did this on a daily basis, Monday to Friday. At the height of the pandemic, all pediatric patients at Cornell were actually transferred over to Columbia, and her daily census rose from an average of like 20 to 30 patients to about 45 patients a day. Additionally, Dr. Smith also started managing adult patients recovering from COVID on the floor. So Dr. Smith had to learn a brand new computer system since she was covering another hospital, and she had to attend weekly meetings to stay up to date with the different policies and constantly changing information. Next slide, please. Dr. Smith, again, provided her services remotely. Her response to the pandemic has led her to expand her role in the health system by providing care to both adults and pediatric patients. She contributed to developing policies and procedures. She provided a wide range of services from optimizing medication management for anticoagulation, pain management, and antimicrobial stewardship, all the way to medication reconciliation for patients on ketogenic diets, to managing the multi-system inflammatory syndrome that was seen in children. She was the sole approver of the use of restricted medications such as intravenous immunoglobulins and also monoclonal antibodies, and that was based off of criteria that were established. She was also part of developing processes and procedures in place for discharging COVID patients. And Dr. Smith was involved in managing drug shortages and clinical trials related to COVID at NYP. So now I'm going to turn the floor over to Dr. Bradley to feature some more of the pharmacy faculty at our college and the response to the pandemic.
Hi, everyone. So I'm going to continue our presentation talking about the role of pharmacist in the community setting. And first, we're going to focus on the expanded role in telehealth. So as was noted earlier by Stacey and Yumi, there was really gaps that became about because of the pandemic, and pharmacists were able to fill in these gaps, allowing for the continuity of primary care through the use of telehealth. So as noted earlier, some US states do allow pharmacists to practice as providers. In New York State, this can be done under collaborative drug therapy management agreements. So pharmacists, if they have one of these agreements, they could optimize, discontinue, initiate medications, perform physical assessments, and order labs. So our pharmacist spotlight here is going to be on Dr. Rickard. He was an assistant professor at St. John's University during the COVID-19 pandemic with a practice site at Queens Hospital, where he served in their ambulatory care clinic. So in March, their clinic went 100% telehealth, And we asked Josh to share his experience with us. And what he said was initially pharmacists were not permitted in the medical record to be able to conduct billable telehealth visits. After canceling all of their in-person visits in June, they had to actually manually keep track of their patients to ensure they didn't fall through the cracks. So Josh actually did weekly and bi-weekly follow-up visits with these patients, and they were really happy to have a healthcare provider following them so closely throughout the pandemic. And on top of providing patient pharmacist care, he was a support system for them as he works in a geriatric clinic and most of his patients are alone. So on top of managing patients' chronic conditions during the pandemic and providing them with support, he worked with central office at New York City Health and Hospitals to actually allow pharmacy to schedule and bill for their visits, which is a tremendous accomplishment in and of itself, and it's certainly no easy task. While doing all of this, he also precepted our St. John's University students and allowed them to participate in these telehealth visits so they could continue their advanced pharmacy practice rotation experiences during this time. Next slide, please. So another major role of pharmacists in the community as frontline workers is in COVID-19 testing. In April of 2020, under the Public Readiness and Emergency Preparedness, or PrEP Act, the FDA authorized licensed pharmacists to order and administer COVID-19 testing. So currently in New York State, over 5,000 pharmacists are performing COVID-19 testing. So we thought this would be a really great spot to spotlight one of our pharmacy students. A lot of our pharmacy students, and majority of them actually, work in either community or hospital settings all throughout New York State, New Jersey, and we wanted them to be able to share their experiences as well. So we're spotlighting Shivani Shah, who is a PharmD candidate 2021, so she'll be graduating this year, and she's a St. John's Pharmacy intern at CVS. We asked her to share her experience, and she said she works at a high-volume CVS pharmacy, which has been turned into a COVID-19 testing site over the past few months. One patient story that left a mark with her was regarding an elderly couple. As new grandparents, they wanted to confirm they were COVID-19 negative before meeting their grandson for the first time. The virus heightened their awareness to control their underlying health conditions, and the couple requested that their pharmacy team conduct a medication reconciliation to ensure they were both receiving treatment for their respective comorbidities. So upon review, Shivani was actually able to help identify and resolve multiple medication discrepancies. The husband was not receiving his insulin for a few months due to an unresolved prior authorization issue, and his wife was taking the wrong dose of her hypertension medication as she was unaware that the doctor had sent over a new prescription and was filling an older prescription at a different pharmacy. So on a daily basis, Shivani speaks with patients regarding their symptoms and helps determine if they're candidates for COVID-19 testing. She then prepares the COVID-19 test kits and instructs patients on how to accurately conduct their nasal swabs and performs medication reconciliation, on top of doing all of the other functions of her job at CVS and being a full-time student in her 6th year of pharmacy school. So Shivani is just one of many students who are contributing so immensely to the pandemic. So we just thought it would be nice to share that with everyone. Next slide, please. Okay, so now we're going to talk a little bit more about the role of pharmacists in academia. As educators, of course, we're responsible for ensuring that our students meet the necessary standards to be practice ready when they graduate and make sure they're eligible for licensure. And in the PharmD program, one of the requirements for students to graduate and get licensed is completion of advanced pharmacy practice experiences, or APPEs. And on these APPEs, students actually go on site and complete clinical rotations to gain expertise in various areas of pharmacy practice. So students will spend their entire 6th year of pharmacy school on site out on these rotations to get that firsthand experience. So what I did here is set up an overly simplified timeline to kind of walk us through the challenges that we faced and overcame as a department to keep our students on track to be able to graduate. And I will do my very best to capture the tremendous amount of work that went into this by so many different people. So if we start at March of 2020, that's when, as we all know, the university suspended in-person education in the setting of COVID-19. So because of this, our department as a whole was faced with restructuring our curriculum and converting those in-person rotation experiences to virtual experiences to ensure the students would receive that same hands-on experience that their 6th year is supposed to provide them. So just to give an idea of how many students we're talking about, we had 240 students in the PharmD class of 2020, and only 6% of them had completed all of their necessary rotations for graduation by March of 2020. So that meant the majority of students still had to somehow finish and complete these rotations in order to graduate and get their licenses and work and help serve the community. So immediately when in-person learning was suspended, we started our contingency planning. And under the guidance of Dr. Tina Kanmaz and the Office of Experiential Education, several different pharmacy task forces were formed, and the entire pharmacy practice faculty worked on creating new syllabi and converting 5 different rotation experiences into virtual format, along with developing a comprehensive COVID-19 training program for all students. And this was all done less than a month later. By April 2020, our virtual rotations began and students were getting back on track to be able to graduate on time. Under normal circumstances, as faculty, we'll typically take 2 to 3 PharmD students per rotation block, take them on site with us so they could learn from at the hospital or at community or clinic or whatever the practice site is. We have a bunch of non-faculty preceptors as well, and because of COVID-19, those non-faculty preceptors or rotation sites were unable to take our St. John students. So what that meant is that we as faculty jumped in and took as many students as we could to help get them the experience that they needed to graduate. So some of us took as many as 7 or 8 rotation students per block. So basically increasing the amount of students by 3 or 4-fold, which is a tremendous amount of work. So we successfully used this model through May and June, allowing the class of 2020 to graduate and meet all of those necessary requirements, and allowing the class of 2021 to get started on their API experiences, all the while planning and preparing for the safe return of our in-person APIs. So as the university began to transition back to a hybrid or in-person learning environment, the Department of Experiential Education began working to place students back on site. And again, this is a couple of hundred students we're talking about, with multiple different rotation sites and multiple different requirements for successful completion. So certainly not an easy task. One of the key components to all of this was ensuring the safety of both the faculty and the students. So in July of 2020, we distributed our first personal protective equipment to students and faculty who were going back on site in just a few weeks. And we developed another comprehensive in-person API COVID-19 training program. So currently, the department is working diligently to match students to either in-person rotations, virtual rotations, or hybrid experiences, taking into account all of these different student factors. We have students who are currently living out of state in different time zones, have different health risks or family issues. So trying to get this all together and done in a successful way has certainly been a challenge, but I think as a pharmacy practice faculty in the department, we've certainly been able to make this successful. Next slide, please. Oh, one back. There you go. Okay, so I just want to give everyone a snapshot of what some of these virtual rotations look like. So Yumi and I actually teamed up for a virtual rotation in an effort to be able to accommodate more students and have more students have these learning experiences. So we utilized Google Classroom and WebEx for interactive case discussions, went over patient cases, journal clubs, etc. We dedicated an entire week of the 4-week rotation just to COVID-19. We asked and allowed students to share their individual experiences. We've had students who've lost mothers, fathers, siblings, who became primary breadwinners for their family. So just giving them the space to have those feelings and support them through it was definitely a big part of our rotation. We also reviewed currently available literature and guidance on COVID-19 and really dissected it and tried to teach the students how to go through that literature and all of the shortcomings of literature being approved on such short notice when we have no information and want it all at the same time. We had them participate in podcasts and webinars, and we also tried to bring that hospital component to the rotation as well by having them remote into various meetings at the hospital. They participated in Pharmacy and Therapeutics Committee, in the Antimicrobial Subcommittee. So trying to meet or, make that in-person experience still come to life through a virtual format. Next slide, please. All right, so we wanted to wrap up our spotlights with a focus on the role of pharmacist in equity. And I think this goes really nicely in tying in with what Dr. Gunness demonstrated through his research. So we know that COVID-19 disproportionately impacts certain populations and is associated with increased mortality in high-risk or at-risk populations that's exacerbated by pre-existing racial and socioeconomic inequalities or inequities in healthcare access and use. So Dr. Vibhuti Arya is a clinical professor at St. John's University. She's also a clinical advisor in policy resilience and response at the New York City Department of Health and Mental Hygiene, and is a racial justice educator and global lead in gender equity and diversity. We asked her, what can we do as pharmacists and healthcare providers to improve health equity? And what she said is knowledge, understanding social determinants, the fact that a lot of communities of color live in multi-generational families, and assumptions and judgments about social distancing can be harmful. Many essential workers are people of color and less wealth, and we have to understand that access is important. Understanding implicit bias, learning how communities of color have been historically disadvantaged, and strategic planning around policies and programs that perpetuate structural racism. So during the pandemic, Dr. Arya worked with a team to develop an equity tool process within the Office of Emergency Preparedness and Response at the New York City Department of Health. And this process involves the actual tool development, training facilitators, piloting and conducting evaluation, and revising the tool. And her work is going to be presented at the Preparedness Summit virtual conference in August 2020. Next slide, please. So on top of all of this, Dr. Arya also does consulting work regarding structural racism and health equity speaking. She does trainings and workshops and strategic planning. And I think one of her most or more impressive, among her many impressive accomplishments, things that she recently did was launch the American Pharmacist Association Public Health Special Interest Group. So this is a national organization with a purpose to promote and advance the role of pharmacists in public health. And it focuses on assessing engagement opportunities for members and addresses the significant public health issues of the coronavirus pandemic and structural racism that continue to affect both the country and the world. So a little bit about how we could educate ourselves as pharmacists to better serve the community and hopefully mitigate some of these inequities that we're seeing in practice. And then I want to leave you with a quote from the Oath of a Pharmacist. It says, "I promise to devote myself to a lifetime of service to others through the profession of pharmacy." And I think through this pandemic and the expansion of pharmacists' responsibilities because of it, pharmacists have really fulfilled this promise in more ways than we probably ever could have imagined at the time when we initially took this oath. And we are obviously don't have enough time, but we have 41 pharmacy practice faculty. I wish we had enough time to spotlight each one of them, but every single person in our college, and I'm sure the entire university, is doing everything they can to help and contribute to the coronavirus pandemic efforts while still trying to support and keep our students at the highest priority. And with that, I want to say thank you all for the opportunity to speak with you today. Project donors, participants, Susan, support staff. And with that, I'll hand it back over to Dr. Gunness.
Thank you very much. Thank you all to the panel for your wonderful presentation. One of the things I wanted to point out was that as a result of the first Power Hour that I presented, it gave birth to a new project looking at Corona Queen specifically to determine whether or not the residents in Corona Queen are prepared for the second wave of. So I wanted to sort of highlight that again at St. John's, in addition to everything that we talked about, we're still working to address the second wave of the pandemic to understand how these communities are affected. So I'll hand it over to Susan.
Thank you, Dr. Gunness. I have to say, thank you so much for such an informative session. But as an alumna of St. John's University, I couldn't be more proud of all of you. And I want to thank you so much for your service and for just following, our wonderful Vincentia mission. And I also want to thank the students as well as part of the College of Pharmacy and Health Sciences. It's really impressive, but it just, when I talk about family, I mean, you're my family members, and I just can't get over the dedication, but the humanity of which you gave to your patients, and how you help your students and how you teach them just, not only the technical, but to be human, because these are human lives that we're dealing with. And this pandemic has been it's been an emotional roller coaster, as you unveiled through all these heartfelt stories. And my sister's a nurse, and she always stresses that remember, the people that you're helping and you're taking care of, they could be your mother, they could be your father. So compassion is very, very important. And I saw that with everything that you talked about. And that really makes me very proud to be part of this St. John's community. So thank you so much. And also, I always respected pharmacists, but I think I have even more respect after your presentation today on all the information and what they had to do during this, the role that they had to take on during this pandemic. So it's very impressive. I know Dr. Gunness mentioned that we have this project. We're able to provide seed funding for it. And I'm excited about that and what Harlem's going to uncover in his research. And we do need additional funding for it. So if anyone is interested in supporting a project that Dr. Gunness is leading, please, by all means, email me after this Power Hour. But we do have questions, and I know we went a little bit over time. But let me just throw out some of these questions. Are very good. Now, someone has nursing homes ? And I know that came up during your presentation, Dr. Gunness. So I'm assuming that they say nursing homes, I guess, in that particular area, or how they were affected.
That's a very good question. I didn't have I didn't have the data to see whether or not specific institutions, deaths from specific institutions were affected or infected, to provide that to you. So I apologize for not having that that available. My specific aim was to really look at what were so New York City Department of Health produces community health profiles, and there are a series of variables such as access to healthcare and whether they have suffering from chronic conditions and or infectious diseases and the income or the rent and the rent burden in these communities, and they are available to the public. So that's where I got my. So I looked at really some of the socioeconomic, environmental factors to see what the relationship was, if any, between the two communities. So I apologize, I didn't have that information available to you on nursing homes and other healthcare institutions.
Thank you. This question was answered, but I will still share it with the group. Why was insulin and heparin given in suboptimal conditions? Was it a lack of needles, or are the needles for subcutaneous different than intravenous needles? I think, Yumi, you responded to the person's question.
Yeah, I saw on the chat, so I wanted to respond
Right.
in case we didn't have time. But I think what probably that question really needed was a clarification. But when I was when sharing Dr. Samantha Moore's experience at Bellevue, it was that because they actually had a lot of shortages with medical equipment and everything. So there was a shortage of IV infusion pumps, which is necessary to have like an IV, intravenous IV infusion. So because there was a lack of those infusion pumps, they weren't able to give drugs like heparin and insulin via an infusion pump. And instead, they had to manage these patients by giving them subcutaneous, insulin and heparin instead. Yeah, I think that was probably, maybe I had spoke a little fast, but just, a clarification in terms of what, why did they not give it via intravenously? And it's because it's the lack of infusion pumps.
Thank you for your clarification. I know in the news, I think it was this morning or last night, they were mentioning about the cases, the number of cases, and the CDC just came out with percentages of the patients that actually died of COVID versus percentages of patients that went into the hospital with already a pre-existing condition. So those percentages seemed very low. I don't know if any of you saw those percentages and want to respond to those stats.
Can you just repeat that again? You're saying that those who died from COVID with underlying medical conditions, the percentages were very low?
Yeah, because I think what the CDC was, and again, I shouldn't interpret. I don't know what they're saying, but from what I think I interpreted the stats to be, is that the percentage was lower because they were recording patients that were 100% COVID patients. I know in the news they were saying that a lot of the patients, when they were discharged from the hospital, they were not discharged as, a cardiac symptom. You know what I'm saying? So what was really pure COVID?
Right. So basically, you're saying that there are issues with underreporting, meaning that for patients who have died, they did not get the COVID test to include that in the cause of death, and which is actually, when you deal with infectious diseases, with something that's spreading so rapidly, and that's causing death. It's hard sometimes because a number of cases, and as Stacey mentioned, the resources in the hospitals so limited, where it's hard to then track, detect, and determine the cause of death. So sometimes they may not have the time to complete the test in time, as well as they may have died before the test results came back. So that's why it's an underreporting. So the percentages that the CDC probably, and I believe what I'm hearing you say is that it is more than what have posted out there or what they put out. And that's also very similar to what New York City has experienced.
Mm-hmm.
If you look at New York City website, you'll see that the number of confirmed deaths versus the number of probable deaths, and the number of probable deaths are, they have a large number of that as well, but they did not include that. They just include the confirmed deaths. So more people are dying that we suspect or we believe from COVID, but it's not or has not or ever been confirmed.
I see. All right, thank you.
Very good question. Very good
I think
question.
we do have another question here. If we have a second wave in the fall, winter, do you think we in the metro area are much better prepared, particularly in those areas that are financially challenged, such as those mentioned in Corona and Far Rockaway?
Very good question. I think the fact
Yes.
that we have a significant decrease in the number of cases, excuse me, and deaths is already speaking to all the implementation of so many strategies to reduce the infection and or prevent deaths. And I think that the Nicole and Yumi really highlighted some of this in terms of through the pharmacist lens on what they're doing, but also on a sort of broader public health perspective. I think we're learning a lot. The way the New York City metropolitan area, the way we're dealing with it, and sort of opening up sort of business or the economy in phases, it's really, it's helping as well. In addition to that, a lot of universities, we're doing this right now at St. John's. We're pushing the wearing of masks. The science has shown that wearing the mask really makes a difference in terms of infection. So that, to me, is really making a difference. When you go around, when I walk around New York City and New Jersey, wherever, I see that. I was in Jackson Heights, which is where the Corona Jackson
Ground
Heights
zero.
area, over the weekend. Yeah, and the majority of people were wearing masks. So you really see that
Yes.
behavioral difference. So I think for me as a public health practitioner is once you see the change in behavior where people are wearing masks, they're isolating or social distancing, they're washing their hands, they have their hand sanitizers, things of that nature. And not just people, institutions, companies, businesses. Once they're limiting the amount of people that come into the store or the amount of customers, that to me is really speaking to why we have a dramatic reduction in infection and deaths. The other thing too is that when you compare ourselves as New York City with another major metropolitan area like San Francisco, they put their guards down too quick, too early, and they let everyone out and people to go back to business too early. We're not doing that. So we may, this is sort of, this is just a prediction based on prior experience, or we may not have a second wave if we continue to, to adapt to our new behavior, as they say, the new normal.
I'm so glad you said that we may not have a second wave, because I fear, I feel like there's so much of a fear factor. And I understand they want to prepare people, you know, and try to prevent it by preparing everyone. But I think sometimes, I don't know if that is doing everyone justice by making people's anxiety level increase. So I'm glad that you said if we have a second wave. That's hopeful and that's promising. And also, you mentioned about the masks. I just read something again yesterday where they were saying that the masks, they're now encouraging people to wear around their family members. So should we go to that
Yes,
extra level?
yes. So what you
Really?
mean, when you say family members, you mean not
They
those
didn't
who you
really,
live with.
Well, no, they didn't specify. So
Okay,
I don't know if you could specify. If I see my mother every single day, I'm not wearing a mask around her. I haven't since day one, and thankfully, so far so good. So when they said family members, I'm like, are they saying now I should put the mask back on and wear it around my mom or my sister or anybody I'm in contact with?
so when I see my mother and my mother-in-law and my family member who don't live with me, I wear a mask. And I
Really?
have asked them to wear a mask as well. Yeah, because again, if we both wear a mask, it reduces your risk is much less.
Right. Oh, that makes sense. Yeah.
Yeah. So
Hmm.
I would advise that if you don't like, if my kids have a play date, all wear a mask. If
Hmm.
someone comes to clean my house, we all wear a mask during that time. So that's how we do it.
And what about if you meet friends for dinner and you have
You
dinner
wear
with
you
them? You wear the
you wear a
mask,
mask until
obviously,
you
when
eat
until you
until you're
eat.
ready to eat.
But
Yeah.
then while you're eating, is there a risk factor there?
Right. So the thing is that that's a question. So
Mm.
yes, there may be, there is a risk factor while you're eating, but if you are wearing the mask most of the time, that reduces the risk. And
Hmm.
yes, there are times where you want to pull the mask to wipe your nose because you sweat. It's these things are normal. It's fine. I
Right.
think the idea is to really get people into the habit of wearing the mask and walking with your mask. And
Hmm.
that's the behavior change that we want to have.
Right.
And hand washing is important. I mean, we always know this, right? Growing up, you
Hmm.
come from outside before you
Wash your
eat,
hands.
wash your
Hmm.
hands,
Right.
things like that. So, like, these are some of the things we want people to sort of, go back to that behavior, or also, or with the wearing of the mask, wear the mask. And there are also some nuance in mask. So I had a question. I'm actually leading the illness investigation response at St. John's University for students and employees. And the question came up about the gator mask that the athletes are wearing. And they're
Mm.
nice, loosely fit gator mask and, stylish and stuff or whatnot. There are specific things about the mask that the mask must do, which is to cover your nose and your mouth as close as possible.
Mm.
Why? So the air droplets don't escape or you don't breathe in the air droplets. And it has to have not just one layer, but more than one layer. So these are some of the things that, it's sort of misleading. And then people would say, well, I wear my mask anyway and I still got sick. Well, it depends on the type of mask you're wearing. I see
Mm.
some people putting handkerchiefs around their noses, but then it's sort of opened up in the bottom here, it's still open. That defeats the whole purpose of wearing a mask. Now,
Right.
granted, there may be some, extenuating circumstances where I have to put a handkerchief because I can't find my mask or whatever the deal is, but if you wear the mask appropriately, which is to cover your nose and your mouth as close and firm as possible to your face, then that should suffice.
No, I'm glad you mentioned that as well, because I see so many people wearing masks and the masks are below their nose and they feel like they're still protecting. So, yeah.
Yeah.
We have a couple more questions and I know we're way over time, so I apologize, but I want to get your questions in. St. John's has not, thankfully, had an outbreak when students return to school as it has happened at other universities like Alabama and UNC. But is it because our students are primarily from New York and they have seen the effects of COVID firsthand? Good question.
Okay, that's an excellent question. I
Mm.
would like to say it's because of me, but that's not the case.
Of course. Of course.
I think that listening to all the measures that St. John's has taken, they have been very proactive. They have given themselves a lot of time to plan this and plan this strategically. I was able to connect St. John's leadership to the leadership of the New York City Health and Hospital Corporation contact traces. And we were able to facilitate a call, an informational call with New York City Department of Health, the Health and Hospital Corporation contact tracing team, as well as universities in the New York Metro City area. And they, for a question and answer forum, and to just sort of provide us some more direction of what we're doing and how we're doing and what what their guidelines are. I think St. John's was really on top of it already, working, tirelessly behind the scenes to prepare the safe arrival for our students and employees on campus. Right now, we have, I believe, a pretty tight um, screening strategy. So everyone who would like to report to campus or come to campus, it could be an employee or a student, they must complete a screening assessment form. And based on the outcome of that form, then you're allowed, it's going to determine whether you're allowed to come to campus. So that on its own, it's going to raise red flags if anything were to come up in terms of your whether you have a signs and symptoms or you've been exposed or come from a state or an area where there is a prevalence of the disease. And I think that in general, we have done, I think, an incredible job. And I think that we are tracking. I mean, during on weekends, it's now that campus is open or school is, we're getting we're tracking and we're figuring out, who's exposed, who's positive, and trying our best to be on top of it. So fingers crossed, that should really, based on what we're doing, we'll be able to predict whether or not when it's effective or not. But so far, it's been very effective. Good question.
No, congratulations to you and the task force committee. What we'll include in our thank you, not only the recording of this Power Hour, but we could probably send the NBC news story. I believe it was NBC. They interviewed you, Harlem, and our students on campus, and it's called Return to Campus. And it's a very good news story. I was impressed, and it really talked about how well St. John's is handling the return to campus during pandemic. So we'll share that with all of you because I think you'll be very impressed by that. Another question, I'll toss it out to the doctors, to the professors. The course offerings have, in light of the pandemic, are there new offerings going to be made because of the pandemic? Has certain courses become more popular because of the pandemic with our students?
Very good question. Very good.
I don't know if Yumi or Nicole, Stacey want to answer.
Well, I can try to answer.
Okay.
In terms of any new courses that are being offered, I don't believe the college has any like new courses, and I can only speak within the pharmacy curriculum.
Yes.
Of course. I don't think we have any new courses that's being offered. However, because we have more like a wiggle room, to say in terms of our API rotations. So the API rotations may be a little different. Like if they come on rotation with us, the faculty who is, precepting the students can absolutely, change certain experiences because, like if the hospital is involved in certain types of like contingency planning for the if second wave arrives, if it were to come, then certainly that faculty can include those students in, those meetings and those preparedness, meetings and communications and all of that. But like hardcore curriculum wise, pretty much I think the pharmacy curriculum is pretty like strict and set in terms of what core classes and courses they have to take. And then once they get to their experiential API rotations, those I think certainly each faculty member or preceptor can have more wiggle room and adjustments in terms of changing certain experiences around, exposing them to different, things that's relevant, or, currently happening within their practice site.
But have all universities, have they ever had any type of course that covered pandemics or how to prepare for a pandemic?
So interestingly, Yumi and I teach in, the infectious diseases elective. It's offered in the spring semester, and one of our lectures has always been on infectious diseases disasters. And until this year, it was kind of a what if, a fun topic for us to all, you know, talk about and think about.
Right.
And then this year, that lecture just took such a different tone because we were, you know, in the height of the COVID-19 pandemic, and it wasn't, you know, as fun to be talking about this when you realize how serious it is and all of the implications from it. But yeah, we certainly cover it. We have been covering it before this, and I think moving forward, we'll definitely continue to cover it, but it'll be through a much different lens.
Interesting. I think we have one more question here. Realize it may be too early to tell, but because of COVID and its impact on society, do you see more high school students applying to the pharma and PA programs?
The physician assistant program, I don't think it's very competitive. We still have a lot of applicants. We have a full class load. Whether or not, I guess it depends. It depends. If you want to go into health, a pandemic is not going to bother you. Just you're protected. The university is protecting the students, the 6-foot distance, making masks worn, the app that you have to have green in order to come into the classroom. So I think that we're not really seeing any change in that because we are doing that. And as for our coursework, like pharmacy, you have those courses that are required, and that hasn't changed. The students just began their experiential once again. They had been on virtual rotations, which we tried to make as realistic as possible. And, you know, with me, especially, you know, all of us who work clinical days, we were able to bring those clinical experiences to the students. So it was almost like they were not missing so much. And we brought them in for procedural skills days where they were able to review blood draws and suturing, skills that they would have needed to have done in person. So everything seems to go pretty much like normal. WebEx, they ask questions. We have office hours through WebEx. So they're getting the same material. It's just they're not seeing our face.
Yeah.
Maybe it's a little bit better because private WebEx, they can talk about, you know, what specifically they're having difficulty with in terms of their education, and we can make an individual approach for them.
Interesting. Well, we have ran well over time, but it was certainly for a good reason. And this has been very, very informative. I want to thank all the panelists. I want to thank the College of Pharmacy and Health Sciences and the students and all the professors that have really just making such a difference in the lives of so many people and helping people. And again, thank you so much for your service during a very challenging time. And September 15th, we have our next Power Hour. As we know, there's so many industries that have been impacted by the pandemic. And because the week of September 15th would have been Fashion Week, our professors from our College of Professional Studies, Collins College Professional Studies, will be joining us to talk about the fashion industry and how it's been impacted by the pandemic. So I hope you'll join us for that. Again, Power Hours are every Tuesday at 1 o'clock. And thank you for all the viewers. We will be sending you information and also a recording of this Power Hour. It's also up on the Office of Gift Planning's YouTube channel. So have a great day, be safe, and like Dr. Gunness says, wear your mask and wash your hands. Thank you. Take care, everyone. Bye-bye.
Thank you. Bye-bye.
Thank you.
Bye.